up the stage for our ongoing clinical trial combining SLM at 3 dose levels, 2,500, 3,000, and 4,000 microgram, given twice daily for 2 weeks. And then on day 15, adding Axitinib at the standard dose and dropping that SLM to once a day. And this was followed by an expansion phase, which we used 4,000 microgram as the expansion dose. We previously presented the safety data, and today we'll present the efficacy data. So our patients included clear cell RCC who progressed on at least 1 line of treatment previously, and no limits on the number of lines of treatment, with the primary endpoint of safety and secondary endpoint of ORR, PFS, and OS. Sorry, I forgot my mask on. So we treated 35 patients. Majority of them were male, and about 63% of them had intermediate risk group per IMDC criteria. I wanted to point out that half of our patients did receive 1 prior line of therapy, and close to quarter received up to or more than 3 lines of prior therapies. And you can see all the previous options listed here, including some patients on Axitinib with prior clinical trials. So in our intention to treat population, 35 patients, 18 out of the 35, accounting for 51 overall response rate. We had 3 patients with complete remission that was durable beyond 2 years. And we had disease control rate of 71%. And then we defined our evaluable population with patients who received 4,000 microgram of SLM and made it to the first scan. And 15 out of our 25 evaluable patient population, accounting for overall response rate of 60% with a disease control rate of 80%. A majority of our responses happened within the first 3 months. Some of them happened beyond 6 months or beyond. Many of them were beyond 1 year, and actually one of Dr. Hans Hammer's is doing well on this combination. Dr. Hans Hammer's patients. Yeah. So this waterfall plot shows the depth of response that we are encountering. 24 out of 35 patients, 69% basically, did have some sort of tumor shrinkage. Our median PFS in the intention to treat population was 9.9 months with a median OS of close to 18 months. In our evaluable population, median PFS of 14.8 months with 21.7 months OS. No concerning safety signal. We previously presented this data. All the side effects listed here are to be expected with single agent Axitinib. Wanted to draw your attention to grade 3 toxicities, including hypertension of 34%, fatigue, and anorexia as expected with Axitinib. We did not encounter grade 4 toxicity related to this regimen. All the grade 4 toxicity listed here deemed unrelated to this treatment, and no treatment-related deaths. We did dual energy CT scan to evaluate the vasculature at 3 time points at baseline T1, at 2 weeks of treatment, after 2 weeks of SLM treatment at T2, and T3 after 2 months of SLM and Axitinib. And we have encountered increase in iodine density, and these were in 16 patients, and a total of 73 metastatic tumors were assessed. We have encountered specifically in the tumor, we have encountered increase in iodine density at day 14, and then at T3, significant decrease in iodine density. And this is consistent with our preclinical data that suggests that selenium is pruning the tumor micro or tumor vasculature and stabilizing the tumor microenvironment, and potentially increasing the effective drug delivery to the tumor microenvironment. And specifically, we have observed this change more pronounced in the lung and liver metastatic lesions. And more interestingly, this change in iodine density was not reflected or did not change significantly in the normal tissue. And this is consistent with our preclinical data too. We were able to achieve mega or high doses of or high selenium concentration in the blood. And we have observed the higher the concentration, better responses, or better responses with higher concentration. We continue to evaluate that in our expanded trial. And just as a reference, basically, our normal selenium level is about 1 to 2 micromolar, and we were able to achieve 117 micromolar here without any added toxicity. And we observed in the tumor biopsies before and after treatment, and we are doing some biomarker work, which is not mature yet, but we have observed that this selenium increase, selenium blood concentration increase is associated with a tumor selenium concentration increase. So in summary, this combination of high-dose selenium and axitinib is safe without death. We had encouraging efficacy data early on, but it's certainly worth evaluating in larger clinical trial. Biomarkers is underway. We are moving forward with a triple combination, SLM, axitinib, and pembrolizumab. It's currently in the startup phase. And with that, I would like mainly to thank our patients and families and thank our supporters, and I will be happy to take any questions.
Wonderful. Thank you, Dr. Zakharia. So, you know, what we're going to do in the interest of time is we're going to run through the first 4 presentations, then we'll have a little pause for questions. So, Dr. Zakharia, you timed in around 7 minutes. Okay, so that's the time to beat. That's okay. That's the time to beat. So, to my friends in the back there, if you don't mind setting the timer for 5 minutes as opposed to 10, you know, thank you very much. Perfect. And we'll go ahead.
I know I'm not going to get the gift,
guys.
I'm not going to get the gift.
You're probably not going to get the party gift, no. All right, so next I'd like to introduce Kevin Zarrabi, who's an outstanding third-year fellow from Fox Chase Cancer Center, working with Betsy and Dan and the illustrious team there at Fox Chase, who will be telling us about real-world patterns of frontline axitinib pembro versus ipi-nivo for metastatic clear cell kidney cancer.
Thank you for that introduction. Can everybody hear me? Let's get started. This background, I think, is not really necessary for this crowd, but over the past number of years, we've seen that the frontline treatment options for metastatic clear cell renal carcinoma has grown tremendously, starting in mostly with combination therapy, starting in 2018 when the Checkmate 214 trial data was released, which led to the FDA approval of ipi-nivo. And then just 1 year later with the Keynote 426 trial, we saw Axi-Pembro data released with an FDA approval. And although these are remarkable advances in our treatment options for clear cell renal cell carcinoma, we don't have head-to-head prospective data to help guide us in treatment choice. When looking at the IMDC criteria and survival, we do know that in the intermediate and poorest patient population, there's no real clear signal advantage in terms of either treatment option. I think common practice is both in terms of practitioner comfort with the combination therapies, as well as patient preference and patient goals. We try to tailor our treatment choice, but there's still an evidence gap in terms of objective data to help discern if there's an advantage to either treatment type. So we partner with the Flatiron Health. And those who aren't familiar with Flatiron, it is a electronic health database. It comprises of 280 both community and academic sites, composed of over 3 million patients and their healthcare data that comes along with them. So we worked with them to do survival analyses in the renal cell carcinoma patients. So taking patients from the years 2018 when ipi-nivo came around all the way through March of this past year when we really started the study, we were able to identify about 1,045 treatment-naive clear cell patients we were able to include in the study, which is a fairly large sample size compared to what's already in the literature. 698 of those patients were treated with ipi-nivo and 347 with Axi-Pembro. Our patient demographics and clinical characteristics were remarkably well balanced. There was no real preference for one agent combination therapy over another in terms of this patient population. I do want to point out the vast majority of our patients, around 80%, were IMDC intermediate poor risk. Greater than 90%, this is kind of a shock, of the patients were actually being treated in community settings. And if you just look at the years, this is the only point where there is a difference. In 2018, when ipi-nivo data was released, more patients were naturally being treated with ipi-nivo, but over the ensuing 3.5 years, there seems to be a patient provider preference to move towards Axi-Pembro. In terms of real-world progression-free survival, in our IMDC favorable risk, I will point out it's a fairly small sample size here. We did see a separation of the curves, a slight advantage to Axi-Pembro. Real-world PFS was not reached in Axi-Pembro, 6.9 months in Ipi-Nivo. Not clinically significant, but again, pointing your attention to that small sample size. In our intermediate and poor risk patient population, which I think is more relevant to this clinical question, we do see a fairly overlapped sets of curves. The Axi-Pembro PFS was 9 months, Ipi-Nivo PFS was 6 months, not clinically significant, of course. In the full intention to treat population, it is overall a similar survival. In our overall survival, in our IMDC favorable risk population, neither for Axi-Pembro or Ipi-Nivo was there any median OS reached. However, in our intermediate and poorest patient population, median OS was not reached for Axi-Pembro and was 22 months for Ipi-Nivo. Again, a complete overlapping of the curves, and that holds true for the intention to treat population as well. When we are able to do our landmark 18-month survival, you can appreciate as the IMDC risk goes from favorable to intermediate poor, survival decreases. However, there's absolutely no discernible difference between the Axi-Pembro treated patients and Ipi-Nivo. Survival seems almost identical. As a clinical fellow, we're taught not to rely on cross-trial comparisons, but I'll go ahead and put the slide up. We now know that both for Checkmate 214 and Keynote 426, as we have the extended follow-up data being presented at the latest ASCO and ESMO conferences, we see that survival benefit is sustained. However, if you notice our real-world patient data set, and this is not surprising, shows a significantly lower survival, both in PFS and OS in our real-world patient of our 1,000 patients compared to the trial populations. Last 5 seconds, again, in the absence of any prospective data, we often rely on cross-trial comparisons and retrospective data sets. This is, to our knowledge, one of the larger data sets currently that we're putting out in the literature. I do want to acknowledge at this past ASCO, there was, I think some of the investigators in this room, someone did a real-world analysis on the IMDC data set, and our data is actually completely concordant. We found the same result, that there's no discernible difference between the 2 treatment groups. We will need longer follow-up, and as we know from the discussions today, we now have Cabo-Nivo and Len-Pem available to us, and over the next year or 2, hopefully as real-world data patients are enrolled, we'll be able to do more analyses. And I will pass on to my next colleague.
Wonderful. Very good. Thanks a lot, Dr. Zarrabi. Great presentation. And so now the time to beat is 5 minutes and 39 seconds. Okay, very good. Very good. So next up is Jasmine Malhotra, who's one of my really outstanding students at City of Hope. She just graduated from UC Riverside undergrad, and she's applying for medical school. And she's going to share with you some of our group's work on COVID-19 in the context of renal cell carcinoma.
Thank you, Dr. Powell, and thank you to everyone at KCRS for giving me the opportunity to present our study, Characterizing the Immune Response in Patients with Renal Cell Carcinoma Following COVID-19 Vaccination. These are our relevant disclosures. So since the FDA approval of the 3 COVID-19 vaccines in the United States, there have been a number of studies exploring the impact of these vaccines in patients with cancer in the way of safety and immunogenicity. As characterized in this table on the right, the seroconversion rates have been relatively high in patients with solid tumors. However, patients with genitourinary malignancies, and more specifically RCC, are not well represented. Therefore, our study sought to determine the biological effect of these commercially available COVID-19 vaccinations in the US in patients with RCC. We included a total of 38 patients, and the inclusion criteria was patients with metastatic renal cell carcinoma who had not yet gotten the COVID-19 vaccination, but had the intent to get vaccinated at time of consent. Blood was collected at baseline prior to COVID-19 vaccination, with additional blood specimen being collected at 2, 6, and 12 months following administration of the first dose. For patients receiving systemic therapy, who represent a majority of the patients in our cohort, additional specimens were submitted during 3 subsequent cycles following COVID-19 vaccination. Serum specimens were then assessed for antibody titers using the SCoV-2 Detect IgG ELISA assay, and results were reported as immune status ratios. So like I mentioned previously, we included a total of 38 patients with a median age of 63 and a majority of male and white patients. 36 out of 38 of our patients were receiving some form of systemic treatment, and a majority of our patients got the Pfizer vaccine. This does not look the way it should, but with various rendered treatments and cycle lengths, antibody titers as assessed by ISR were assessed at different time points following administration of the first dose. And this graph provides a comprehensive overview of the trend in ISR across each of the 38 patients across time. And our results demonstrated a seroconversion rate of 92% by the 2-month time point. Further, there was no difference observed in the seroconversion rate across different treatment types, particularly immunotherapy versus targeted therapy for our patients, or across vaccine administered. So while a majority of our patients did demonstrate positive titers by the 2-month time point, 3 patients did fail to seroconvert. Of note, patient 1 had had recent surgery, was clinically malnourished, and only received the first dose of the vaccine. Patient 2 was on immunosuppressive treatment, and patient 3 had chronic kidney disease. In conclusion, our data suggests a sufficient COVID-19 antibody response in a majority of patients with MRCC who received a commercially available COVID-19 vaccination. In terms of limitations, while our study does represent the largest cohort to this date with patients with MRCC in this space, we do still have a relatively limited sample size. And due to variations in clinic visit times and treatment cycle lengths, our specimen collection did lack synchrony across patients. Specimen collection is ongoing to assess for any changes in ISR values at the 6 and 12-month time points, as well as following administration of the recently FDA-approved booster dose. We will be conducting further analysis through T-cell receptor sequencing to identify vaccine-induced clonotypes. Moving forward, future efforts should focus on possible clinical reasons for those individuals who achieve suboptimal antibody titers across studies. Before I wrap up, I just want to thank the patients and their families for participating in the study. I want to thank our department chair, Dr. Salgia, and my wonderful mentor, Dr. Pal, and the rest of our awesome team at City of Hope. Thank you all again for this opportunity.
Great job, Jasnoor. That's actually going to be a pretty tough time to beat. She registered in at 4.5 minutes there. So I think that's going to be the time to beat here. Next, it's my pleasure to introduce Dr. Nicholas Sayegh, who's a really outstanding research fellow at the Huntsman Cancer Institute, working under the direction of one of my good friends, Dr. Neeraj Agarwal, who's going to be presenting a really interesting abstract related to histologic growth patterns in nephrectomy specimens of clear cell renal cell carcinoma and the relationship to tumor evolution. Nicholas?
Okay, thank you, Dr. Pal. And thank you, KCRS, for this opportunity. So I'll be talking today about our study showing that histologic growth patterns in nephrectomy specimens can inform about the tumor evolution in clear cell renal cell carcinoma. So as a small background, 30% of RCC patients present with metastatic disease, and also 30% of patients with localized disease progress to metastatic disease later in the disease course. But currently, the prediction of the risk of metastatic progression is based on clinical factors, mainly the tumor size, tumor stage, tumor extrarenal invasion, and renal vein thrombosis. Moreover, the actual ISUP grading system is mainly based on nucleoli characteristics for grades 1 to 3 and on the presence of sarcomatoid and rhabdoid differentiation and giant cells and nuclear pleomorphism features for grade 4. However, there have been some conflicting results concerning the grades 2 and 3 to predict outcomes, especially metastatic progression and overall survival. So we hypothesized that the progression from low grade to high grade in clear cell RCC is related to the evolution of histologic growth patterns. So we examined 24 different histologic growth patterns from 147 patients, out of which 107 are metastatic and 40 are non-metastatic. So we also measured for each histologic growth pattern the hazard ratio for overall survival using a Cox hazards model and the pairwise co-occurrence using the phi correlation coefficient. The median follow-up for the entire cohort was 6 years, and the metastatic group had a higher age. And as expected in the metastatic group, we had bigger tumors and higher rates of extrarenal extension, renal vein thrombosis, and necrosis. So using the correlation coefficients, we built this pairwise correlation matrix where we noticed, as expected, the highest correlation to be between the sarcomatoid rhabdoid features and the nucleolar grade 4. Also, some modest correlation was also noticed between the tubulopapillary, tubular, pseudopapillary, and nucleolar grade 3 features, showing that tubulopapillary patterns can be correlated with high-grade nucleolides. So using the hazard ratios for overall survivals and correlation coefficients, we hypothesized that this tumor evolution could be predicted. So as we see here, the tumors could start as small nests and then go through two pathways, either a mesenchymal pathway or a tubulopapillary pathway. So the mesenchymal pathway has overall survival hazard ratios ranging from 2.3 to 3.3, and it was almost exclusively seen in metastatic cases, as we see here. So it was seen in 44 over 107 metastatic cases, while it was seen in only one case that was not metastatic over the 40s. And the other pathway, which is the tubulopapillary pathway, an epithelial pathway, has the highest hazard ratio of 1.4, which is pretty different from the other pathway. So something worth mentioning is that both these two pathways were mutually exclusive in the majority of cases. So as a conclusion, clear cell RCC starts as small compact nests that evolve through two different pathways, epithelial and mesenchymal, the latter being almost exclusively seen in cases that metastasize. However, the fact that some metastatic cases, or mainly, half of the metastatic cases that we had more, did not have this mesenchymal pathway, showing that there might be an emergence of metastatic clones within the tubulopapillary histologic growth pattern regions. So the next step would be to identify the molecular drivers in these tubulopapillary regions and maybe identifying novel therapeutic targets. I would also like to thank you for your attendance and thank KCRS for this opportunity, and thank my mentors, Dr. Niraj Agarwal and Dr. Deepika Sarohi.
Alrighty, so now we're gonna move into questions. I'm gonna have our audio team give us a 10-minute timer here. We'll have 10 minutes of questions for the first 4 speakers. So, do you have a question?
I have a question. Can I ask?
Yeah, sure.
Yeah.
The last speaker, Nicholas, can you, do you have a pattern of what the metastatic lesion looks like in these patients?
We did not include any metastatic site sub-analysis in this study. However, we are currently investigating a higher scale studies, including the metastatic sites and also the molecular drivers.
So Yousef, oh, sorry, I'm over here.
Oh, go for it.
Does selenium have any bad side effects?
I'm sorry?
Does selenium have any bad side effects? Anyone problems with eating tons of selenium?
Yeah. So in previously published data, actually in phase 1 setting, using as high as 7,200 microgram twice daily in head and neck cancer population, believe it or not, the only side effects was the garlic breath. The patient will complain about that. This is published data by I think Marwan Faqih now at City of Hope. But on its own, at least in our data, we did not encounter any issues related to selenium, and especially we treated patients for 14 days with selenium alone, and we did not encounter any side effects. And there is a rationale for that. from our preclinical data, stabilizing the tumor microenvironment before introducing the cytotoxic material or the targeted therapy.
A question for Kevin. So in the Flatiron database, how was the risk score calculated? How was IMDC risk calculated? Like,
Sure. So we actually did an extraction originally applying our own criteria, calcium, neutrophils, platelets. And then miraculously, I don't know if anyone else, there was a mass email sent out to any Flatiron users that they are now incorporating IMDC risk as part of their basic extraction. So they did it for us based on EMR data.
okay, got it.
And I will add, when we compared our original data where we applied IMDC to the extracted data where Flatiron did, it was totally concordant.
Oh, very good, very good. And Kevin, just to follow up on that, great presentation. Will there be an opportunity to look at some of the other contemporary regimens like Cabo-Nivo and Pembro? with your
Absolutely.
data set?
At our March 1st, 2021 extraction, there were just not enough patients on Len-Pem and
Sure.
Cabo-Nivo yet. But and I skipped over my acknowledgement slide, which I'm embarrassed. Dr. Geisman is my mentor and PI, and Dr. Plemak and the Akshi's team has been supporting me through this. I imagine we'll be doing ongoing analyses.
Fantastic.
Scott, yeah.
Hi, yes, the same, Dr. Zarrabi. When you do the database data that you have access to, how do you define what equates to progression? What's the duration of therapy that you're able to identify?
Sure. So it will be a surrogate. In our case, it could be defined based on your investigator choice. Working with Flatiron, we looked at when patients went on to next line of therapy. So it wasn't exact, like in a trial where we have exact PFS data. This is real world data sets are not as perfect in a way.
What about the subset of patients that never go on to another line of therapy? If they get sick and die, I mean, a significant portion won't get second line therapy. So how do you handle that?
So we do have death records included in the patients. That was part of our inclusion criteria to be included in the analyses.
Okay, thank you.
Sure. I apologize for not clarifying that in my methods.
Great. Any other questions?
Wow, we're right on
Good.
time here. Excellent. Should we just keep rolling then,
we should
Rana?
roll.
Okay, very good. Well, so far, I think Jasnoor is in the lead here with a presentation that was 4 minutes and 30 seconds. So let's see if we can keep these next couple under 5 minutes here. It's my pleasure to introduce virtually Dr. Lucia Carrillo-Ajuria from University Hospital 12th de Octubre, who's going to present to us transcriptomic analysis predicts resistance and toxicity in MRCC patients treated with ICIs. And the senior author here is one of Tony's former fellows, Guillermo de Velasco. So welcome, Lucia.
Thank you very much. So I'm going to share my slide up. Where am I now? Here. Up. There. So thank you very much and congratulations to all the previous speakers. And thank you for giving me the opportunity to talk about the role of transcriptomics in predicting resistance and toxicity to IC metastatic RCC. Oh, I can move them. Yeah. Okay. So we already know, and we've talked a lot about it, IC combination therapy has become the standard of care in first-line setting, but we don't have a single validated biomarker of response to these therapies to date. So several gene signatures have been developed within clinical trials with promising results, but unfortunately, the Checkmate 214 showed us that the immune signatures were not predictive of efficacy to Nivo, EP, and angiogenesis signatures were neither predictive of overall survival. So our aims and the aim of this study was to identify distinct gene expression profiles associated to response or resistance to IC in a cohort of metastatic RCC patients treated sequentially with IC and TKI or vice versa, patients from the clinical daily practice. If no differences were found, we would try to identify distinct gene expression patterns associated to response and resistance, but in a selected subgroup of patients. So one approach would be a extreme responder approach. We would compare responder patients to IC, but refractory to TKI versus patients that had been refractory to IC, but responder to TKI. And the other comparison was to see if we could find gene expression patterns associated to patients developing severe immune-related toxicities versus those that didn't develop these severe toxicities. For this, we performed an retrospective microarray gene expression analysis. 92 RCC patients treated with IC at our center were identified, 73 with available tumor sample, and finally 66 arrays were performed. Gene set variation analysis, gene set enrichment analysis, and MCP counter analysis were performed. However, for our first aim, despite we were comparing patients with very different clinical behaviors, no differences in expression of different immune-related pathways were found. So we switched to the next stage, and that was trying to identify specific gene expression patterns associated to either extreme responses or severe immune-related toxicity. Again, the gene set variation analysis did not show any differences between the two groups from the green extreme responders approach, and neither we saw any differences between the patients developing severe immune-related toxicities or those that didn't develop them. What we did see with the gene set enrichment analysis was that several key biological pathways were enriched in the refractory to IC but responded to TKI patients. And also we found several pathways that were also enriched in the severe immune-related adverse event group. Particularly, and what we found interesting was that interleukin-2 STAT5 signaling was active in both groups. So it is true that our study has many limitations. You can all read them, all of them there, but it's true that we thought it was interesting to find a pathway that was both enriched both in the refractory to IC, but responding to TKI patients, and in the group of developing severe immune-related adverse events. We have made a great effort to find a biomarker of response, and we haven't found them to date, but it's true that maybe we should focus on trying to find a biomarker of trying to find which patients, in fact, do not benefit from IC, maybe because they are resistant, but also because of the severe toxicity. We're going to try to validate these results in an independent dataset. What it seems clear for now is that we still don't have a biomarker. It seems it's going to be difficult to find binary biomarkers such as, for example, the HER2 in breast cancer. And what we need to do now is try to maybe try to develop molecular-driven trials like the Bionic trial, maybe with a novel RNA sequencing techniques such as single-cell RNA, digital spatial profiling, and maybe also combining different biomarker scores, because to date, I think that's all we have for now. Thank you very much, and thank you to all the patients and the 12 de octubre and the MAPS team. That's all. Thank you.
Amazing. That was
Hope I stick to the 5 minutes.
5 minutes. Well done. Right at 5 minutes. Very good, Lucia. Thanks a lot. So we're going to bring you back in just a moment for the Q&A session, but it's really my pleasure to invite up to the stage Dr. Alex Chirazzi Raffel, who's my fellow at City of Hope. He's a third-year fellow. I actually probably have emailed a lot of you in the room about him. He's going to be graduating next year. My hope is that we'll be able to keep him on as faculty at City of Hope. But he's going to be presenting a really interesting project looking at ultrasensitive ctDNA platforms for MRCC. Alex?
Thanks so much, Dr. Powell. Yeah, so today I'll be sharing with you guys a study we conducted called Ultrasensitive ctDNA Distinguishes Partial Response from Complete Response with Immunotherapy in Metastatic Renal Cell Carcinoma. I have no disclosures. Okay. Oop. There we go. Okay. So as we all know, circulating tumor DNA or ctDNA has several applications, including the detection of actionable mutations and the detection of MRD. However, for RCC, one of the major challenges in the latter has been the depths of sequencing. For instance, using up to 16 clonal mutations, a previous study achieved a negative predictive value of only 51%. Targeted digital sequencing, or TARDIS, is a novel bespoke assay that ascertains up to 100 patient-specific baseline mutations. To assess its efficacy in the setting of RCC, we sought to determine the association between variant allele fractions, or VAFs, and depth of response. Secondarily, we sought to determine if those VAFs are associated with disease progression on subsequent imaging, which was assessed using CT as part of routine care. We included patients who achieved a CR or PR to an ICI and permitted all histologic subtypes, IMDC risk, and lines of therapy. ctDNA analysis was drawn at a single time point, and patient-specific mutations were identified using whole genome sequencing. We enrolled 23 patients, 8 of whom had tissue unavailable for whole genome sequencing, and 3 had non-viable plasma samples due to suboptimal primer panel development, which left us with a total of 12 patients. Here are patient demographics. You can see most patients were male and had clear cell histology. 11 out of 12 were intermediate risk. Most patients were on first-line therapy, and treatment was split evenly between ipi-nivo and nivolumab monotherapy. Here you can see tumor genomic profiles for all 12 patients. That was obtained using whole exome sequencing as part of routine care. As one would expect, tumor mutational burden was pretty low across the board. And we saw 8 out of 12 patients carrying VHL mutations. Similarly, PBRM1 and BAP1 was mutated in 2 out of 12 patients, which would also be expected. But of note, SMARCA4 was present in 3 out of 12 and is typically not associated as much with RCC. So we used an average of 30 patient-specific mutations, and that was used for the quantification of VAFs, and achieved an average coverage of 103,342 read families per sample. On this slide, you can see some clinical characteristics as well as some of our VAF results. Right here on the left, you can see in the bottom row, we have a clustering of progressive disease on subsequent imaging in those patients with higher VAFs. And as one might expect, to the far right, in lower VAFs, we have those who had complete response. Using Mann-Whitney U tests, TARDIS achieved a significant difference between those with a PR and CR, the p-value of 0.018. At an optimal threshold of 0.03 VAF, TARDIS achieved a sensitivity of 89% and specificity of 100%, and an AUC of 0.96. Similarly, TARDIS using Mann-Whitney U analysis had a significant difference in VAF between those who sustained PR or CR and those who progressed on subsequent imaging, with a p-value of 0.026. At an optimal threshold of 0.15% VAFs, sensitivity was 83% and specificity 100%. AUC was 0.92. So in sum, this study represents the first application of a ctDNA to effectively discriminate between partial and complete responses to immunotherapy and MRCC. TARDIS maintained a high sensitivity and specificity for predicting progression and may be an efficacious platform for detecting molecular residual disease and relapse in MRCC. I'd like to thank our collaborators over at TGen, our chair of oncology, Dr. Salgia, my mentor, Dr. Powell, and the rest of our team at City of Hope, and most of all, our patients for all their help and support throughout the process. Thank you.
Excellent, Alex. Perfect. And right at 5 minutes, no less. Wonderful. You guys are going to love the prize that I have for you at the end for the winner here. It's good stuff. So next, I'm delighted to invite Dr. Jason Muhich to the stage from Roswell Park, who's going to discuss seeking the source of radiation-induced anti-tumor immunogenicity in renal cell carcinoma.
Thank you, and I'd especially like to thank the organizers of this meeting. It's been a wonderful meeting, and it's a pleasure to present this research to you today. There we go. So there's now more than 400 clinical trials that are evaluating radiation and immunotherapy combinations. But surprisingly, there's been very little investigation to what is actually happening in the tumor microenvironment in patients following treatment. So here's I think a very unique clinical trial that was performed at Roswell Park a few years ago, performed by Tom Schwab and Anu Singh, where Anu treated patients with renal cell carcinoma with 15 gray SBRT to the primary tumor. And then Dr. Schwab, 4 weeks later, resected that same tumor. And this trial gave us the unique opportunity to evaluate what was happening in patient tumors. And Monty has this prize right now, these 5-minute presentations, so I'm not gonna have time to tell you about the TCR data, but I will tell you, this is published in PNAS. What we showed was that the same clonotypes that were present in the tumor microenvironment, those clonotypes expanded 2 weeks after SBRT treatment. So we saw the same TCR clones go up at 2 weeks, and then surprisingly at 4 weeks, they actually contracted back down. And that was a very interesting observation that we had. From the RNA sequencing analysis, we did bulk RNA sequencing at first, and we evaluated, like many of us would, using volcano plots and pathway analysis. And there's no filtering here when I'm showing the pathway analysis. So what we're seeing, just doing bulk RNA sequencing of these patient tumors following SBRT, there's no immunotherapy, but you can all see, by and large, we're seeing enrichment of immune pathways across the board with SBRT. But this really, there's limitations of this technology, right? We can't get an idea of the source of these signals and what's truly happening between the immune components and the tumors. And to do that, we evaluated these same patient tumors by single-cell RNA sequencing technology. And we initially just looked at the map to see the relationships between the different cells, and we can identify CD8 T cells, CD4 T cells, tumor cells as well. And this really allowed us to distinguish what radiation was doing in the context of RCC. And just to give you a sneak peek of our results, we first looked at the CD8 T cells, and we can clearly see that there's an increase in activation, exhaustion markers. We see an increase in interferon gamma in our CD8 T cell populations. We also see an increase in proliferation and cell cycling, which matches some of our earlier work in these same patient tumors, looking at Ki67 expression. So we also perform pseudotime analysis of the CD8 T cells. We can identify distinct populations and also see perhaps how they're transitioning between the different populations. We can look at naive and stem-like markers, as well as exhaustion markers like TIM3 and LAG3, of course, PD1, to distinguish the different subsets. And when we look between a nephrectomy only and patients that were treated with SBRT and then nephrectomy, there's a very clear distinction. We can see an increase in naive and stem-like populations in the nephrectomy-only patients, as well as an increase in effector and exhausted populations with patients that were treated with 15-grade radiation. Important to note, we also see that with radiation, there's an increase in this interesting population that's been described that has expression of PD1, but lacks expression of TIM3 and LAG3. We also evaluated the tumors, the cancer cells following treatment. And we see increases or enrichment of antigen processing pathways. And looking specifically at genes that are changed or enriched in SBRT, we see increases in HLA expression, as well as calreticulin and tumor-associated antigens that could be important targets. And perhaps there's increased immune recognition following radiation treatment. So just a quick summary slide. I didn't have time to show you this all today, but we see acutely an increase in some of our other models with radiation, increases in antigen and things we think are important for immune recognition. Following radiation treatment in patients, we see an increase in clonotypes that are within the tumor in the peripheral blood at 2 weeks, and then contraction at 4 weeks. And the tumor cells themselves had increased expression of calreticulin and tumor-associated antigens. With that, of course, I'd like to thank our patients and their families, our funding sources, Dr. Jackie Chow in my laboratory did a lot of this bioinformatic analysis. I'd also like to thank Tom Schwab and Anu Singh, who coordinated this clinical trial. Thank you.
That's over 5 minutes, but I appreciate your commitment to the 5-minute rule. Thank you, Jason. So I'm going to introduce Nick Salgia. This is actually a wonderful story. So Nick is an MD PhD student at University of Buffalo. He worked with me at City of Hope for 2 years. And I just found out yesterday over dinner that he's actually going to be doing his PhD in Jason's lab. So, everything's sort of coming full circle, which is really amazing. But he's going to present some work related to papillary renal cell carcinoma at our institute.
Great. Well, thank you, Monty. And so I know I have this unique privilege today of being the last presentation at KCRS 2021. And Monty, I promise I want to win this award. I'm competitive, you know that. But I'd rather take 30 seconds and really acknowledge the people who have made this all possible. The moderators, of course, but also the scientific committee. And most importantly, I think the folks from KidneyCan who have done an amazing job of organizing this and bringing it to fruition. So with that, I think I can get into my project here, and we're really exploring the tumor microenvironment in papillary renal cell carcinoma. And let's get started here. I'm a lowly medical student. I don't have disclosures. Maybe one day, we'll see. But the tumor microenvironment in renal cell carcinoma has begun to become well-defined in clear cell, right? We know that it is a rich immune infiltrate tumor in some ways, defined by lymphoid, myeloid compartments, epithelial compartments, stromal, endothelial, etc. Excuse me, I'm going to remove my mask here as well. And it's really the target of almost every therapy in renal cell carcinoma. However, we don't have an understanding of what it is in papillary RCC, not to the degree that we do in clear cell. And so that's really what we tried to uncover here. And we use a technique known as imaging mass cytometry, which uses heavy metal label antibodies to stain and then probe for specific cell markers. And you can see a 12-marker panel we designed with Fluidigm and the thoracic team at City of Hope in order to investigate the tumor microenvironment. And we had two aims, and I'll start with the first one here, and that's comparing clear cell to papillary renal cell carcinoma and what the immune environment actually looks like. So we took 33 total patient specimens, 10 clear cell, 23, all baseline, all metastatic, so either primary or metastatic lesions, let me clarify there. And there's no significant differences in any clinical pathological features. I do want to point out overall survival was much larger in the clear cell cohort, as you might expect, 64 versus 28 months respectively. And when we pull out the Tisney plot of all the cells analyzed through this IMC analysis, you can see distinct clustering of the clear cell and the papillary RCC. So we dove into that a little bit farther and actually looked at cell propensity and cell preponderances here. And first looking at CD3 positive T cells, and then their subclones, CD8, CD4, your FOXP3s. No significant differences in lymphoid lineages were established between the two histological subtypes. However, on myeloid markers, particularly CD68 for our macrophages, and then also arginase 1 for MDSCs or M2s, right, depending on co-expression, were significantly upregulated in clear cell renal cell carcinoma. So with that, aim 2 now looks at clinical response and potential prognostic markers to clinical response. And of course, I'm sharing the stage with Monty, my mentor, and he recently published the PAPMET trial, which has already been discussed today in depth, which showed for the first time randomized evidence supporting a survival benefit with MET inhibition in papillary renal cell carcinoma. And so in our papillary cohort, we found 19 patients who at one point received a MET inhibitor. And I'd like to clarify, this is at any line. And again, these tumor samples are all from baseline. But we used a recursive partitioning analysis to stratify these as clinical responders or non-responders. And we found that in clinical responders, those who had an overall survival of greater than 20 months, baseline macrophage populations were abundantly higher. And so I'm going to lead into discussion here, and two key points to take away are that the tumor microenvironments between clear cell and papillary renal cell carcinoma are different. In particular, it appears that clear cell renal cell carcinoma presents with a more immunologically cold phenotype at baseline. And then secondly, macrophages may play a prognostic role at baseline of determining whether or not a patient will respond to MET inhibition. I'd like to qualify this in many ways. This is a very small sample. This is purely baseline. There's no temporal analysis. This is purely correlative. There's no mechanistic analysis. But these are unique novel findings that suggest that biomarkers maybe expand beyond just MET amplification, and MET expression in papillary renal cell carcinoma. And I'd like to close my time here just by saying we are in a unique position in this field. I have been learning over the last 2 days. Many of you have been learning and sharing, but the tumor microenvironment is such a novel concept still. And we are now beginning to appreciate these techniques, and combining these techniques, combining these analyses, and combining our brain power will allow us to better expand our knowledge of the TME, and in turn better expand our knowledge of renal cell carcinoma. So thank you. Lastly, sorry, I'll just gotta say a few thank yous. Monty, of course, his team. I think we've seen this picture 30 times today. Hai Ching Lee from Bioinformatics, who is instrumental to all these analyses, and then the folks at my new home at the University at Buffalo and Roswell Park as well. So thank you, everybody.
Thanks. So I know everybody's been waiting for this. It sounds like Jasnoor came in first with time, 4 minutes and 30 seconds. So I know someone who knows someone. What I got for the winner of this session is a free year-long subscription to the Your Amigos podcast. So congratulations, congratulations. Enjoy. Brian, fantastic. Yes. I'll turn it over to Rana for questions.
Great. We've got 10 minutes for questions, so I don't know if you guys want to cue us. So first we'll take questions from the room here. Anybody for our last four speakers, or anybody? Okay. We do have a question from our virtual room here. This is from Mary Lee. Does MNSOD2 gene polymorphisms associate with the selenium effect in RCC? So this is for Yousef.
Honestly, God knows. I do not know the answer to this, but I mean, we obviously know that selenium has antioxidant properties. So we are working with the what do you call it, the oxidative group at the University of Iowa to try to figure out the exact correlation there. But I do not have, I'm sorry, I do not have the answer to this question.
Tony, do you have a question?
Yeah, one question is for the bespoke assay, the TARDIS technology. So I wonder if you have any data in the adjuvant setting or in a setting where you have a non-metastatic kidney cancer, and whether some of this mutation, and I believe you picked 16, it picks, you know, it could be not real mutation, but something like germline or chip or something like that, if that's a possibility. And second, in non-metastatic, the data.
Sure, yeah. So to your first question, for adjuvant, we don't actually have that just yet. We do have a previously published trial in breast cancer that was in Science Translational Medicine, published by McDonald and colleagues that looked at neoadjuvant therapy. So in that context, yes, but for RCC, it's still very fresh. As for how many mutations we use, the example I gave in the background was 16. We actually used 30 with a range of 19 to 35 mutations using whole genome sequencing rather than exome.
Yeah, and Tony, in our assay, there is correction for germline with blood, so we actually are able to sort of refine our technique to just look for what we feel are.
And that's one of the advantages collecting. And wonder if you know, corrected for chip. And the second, you know, this seems to be a bit, you know, more sensitive and specific than the Natera, because there, at least in the Nature paper with Tom Powell's, they had 2 or more that were called positive. How did you make the calls? How many mutation you need to have from the original sequencing of the tumor to call it positive? Or on average, how many you end up with?
Yeah, so we took a slightly different approach rather than saying positive or negative like the Natera bespoke assay. We looked at VAFs. So we looked at variant allele fractions. And it was really just to discern whether it was a CR or PR. So we're really not at a phase yet where we can say someone's, you know, MRD positive or negative. It was really just a preliminary analysis to see if there was correlation or association between VAF and extent of disease response on CT.
Question for Jason. So you mentioned that the immune response to radiation tended to wane by 4 weeks. Do you have a sense of what the mechanism is for that loss? And what does that say about using radiation to in combination with checkpoint inhibitors?
So here we're looking at in peripheral blood, we're looking at the clones that are present in the tumor microenvironment. So we could be observing two processes here. So one is after radiation, you have immune activation, you have expansion of T cells, and that's what we're observing at that 2-week time point. You have those clonotypes that all of a sudden are enriched and in peripheral blood. And the other processes that could be happening with radiation, you might also see improved T cell entry and accumulation in tumor microenvironment. So it's possible that it's not necessarily waning, but the T cells are reaching their site of their destination. They're making their way to the tumor microenvironment. And the clonotypes that we're investigating, they have reached their destination at that point. So that early phase immune activation may have waned at 4 weeks, but you have an active response happening at that 4-week time point in the tumor microenvironment.
But didn't you resect those patients or weren't those nephrectomy specimens? So could you see them in the
Yes.
tumor microenvironment at 4 weeks?
Yes. So the same. So in this trial, we didn't have a pre-treatment biopsy. So everything we're evaluating at that 4-week time point are the clonotypes that are present in tumor microenvironment.
Yeah, so also on that, so SBRT is like very, very high dose. I'm just not understanding why they're not all dying, the T cells.
The T cells, why they are, yes. So
Or did they come in later, in other words?
well, there is a lot of investigation with this in murine models, and there's groups that have shown that T cells are more resistant to radiation in the tumor microenvironment than they would be at peripheral sites. And then there's the question of whether what we're looking at that 4-week time point are those tumor resident CD8 T cells that were there at the time of radiation, or whether they're newly recruited.
Yeah, again, fascinating work with SBRT and all what you're doing. I do wonder if you have data or you think it could be different if using something else like radiopharmaceutical. For example, Dr. McKay has an intergroup trial with radium cabozantinib versus cabozantinib in these metastatic, bone metastatic renal cell cancer. Do you think you'll have the same effect perhaps?
I don't know. That's a great question. So I think here we're probably observing again at that initial 2-week time point is a result of immunogenic cell death. And if that therapy can induce that same level of immunogenic cell death and has a tumor draining lymph node to support expansion, to support expansion of those T cells, then I think you might see a similar response.
Just a question about timing. So there's kind of a temporal relationship happening of what's happening with the T cells within the tumor microenvironment. So when would you think would be the optimal timing for introducing a checkpoint inhibitor? Like before, during, after, should you keep retreating with SBRT? Like, I think the timing actually really matters.
I think that what we're running into, Monty, is we should have expanded that 5-minute window. We didn't show the TCR sequencing data.
I'm sorry.
So it matters. My view on this is we're still learning a lot more about how radiation works, and it's been around for 100 years.
Yeah.
And we're still learning how PD-1 and CTLA-4 work, and they're new, right? So if that initial expansion of T cells at that 2-week time point is important for IPI, then there's your window. If it's more important that those phenotypes are present in the tumor microenvironment at 4 weeks, we might have defined the window there to be at 4 weeks. But this is just at 15 gray in renal cell carcinoma. I think there's also questions that need to be asked about dosing, regimens, and different tumor types and what happens.
Fascinating. Well, I think we're going to probably go ahead and close the session now right on time, exactly at 60 minutes. And we're going to turn it right back over to our
Tony and Hans.
meeting leaders here. Yeah, Tony and Hans. Thank you, everyone.